in the series focused on community-defined practices for ethnic and cultural populations, brought to you by the California Institute for Mental Health, our Center for Multicultural Development, and presented by our partners, the Asian Pacific Policy and Planning Council. We would like to thank our sponsors, the Mental Health Services Act, and the Department of Healthcare Services for supporting this webinar series. Our webinar today is titled Outreach and Engagement Practices with Diverse Asian Pacific Islander Communities. It will highlight salient issues within the diverse API communities. Strategies of outreach and engagement will demonstrate the conceptualization of services within the context of community and families, incorporating factors such as immigration, trauma, stigma, and access to services. Examples from the innovative integrated service models in California will help practitioners re-examine cultural notions of mental health, wellness, and recovery. It is a privilege to have with us today's facilitator, Dr. Trang Hoang. Dr. Hoang is the Division Director of the SSG Alliance, overseeing multiple programs serving adults with mental illness in Los Angeles County. She is a licensed clinical social worker with a PhD in social work from UCLA. Since 1990, she has been working with the Southeast Asian and API immigrant populations in Los Angeles. She also worked with Vietnamese refugees in the Philippines and developed social work training in Vietnam and in the Asian Pacific region in 1993 to 1998. She was a faculty member at CSU Santa Barbara, and is currently teaching part-time at the USC School of Social Work. Also with us today are the following presenters: Mariko Kahn, Grace Park, and Hoang. Mariko, Ms. Kahn, has a wealth of knowledge and experience serving the Asian Pacific Islander communities. Ms. Kahn earned her Bachelor of Science in Cultural Anthropology from the University of California, Riverside, and has a Master of Arts in Clinical Psychology from Antioch University. Ms. Kahn has served on Asian Pacific Policy and Planning Council since 2005. Ms. Kahn was appointed to the Los Angeles County Department of Mental Health Systems Leadership Team in 2010 and appointed to the API Innovation Integration Review Team, as well as the Workforce and Education Training for Los Angeles County, DMH. Our next presenter is Ms. Grace Park. Ms. Park graduated from UC Berkeley in 2003 with a Bachelor of Arts in Social Welfare. She worked in residential treatment with pregnant and parenting teenagers and saw firsthand the complex nature of the field as her clients were involved in multiple systems, including child welfare, probation, education, health, and mental health. In 2007, Grace completed a Master's of Science in Social Work at Columbia University, where she focused on family, youth, and children's services. Ms. Park worked as a children's therapist for the Koreatown Youth and Community Center. She provided direct mental health services to Korean American children, youth, and their families through Los Angeles County. Ms. Park became certified as a positive parenting program provider and a managing and adapting practice provider, and became a licensed clinical social worker in 2011. Ms. Park left clinical work to pursue her interest in program development and helped to launch an academic intervention program for at-risk youth in New York City. Recently, Ms. Park returned to KYCC in Los Angeles as the program coordinator for the Korean Integrated Services Management Model. She currently leads a collaborative that provides holistic and culturally effective programming for the Korean community, which has been identified as an underrepresented ethnic population in Los Angeles County. Our final presenter is Hoang. Ms. Wen received her bachelor's degree in English from China and came to the States to study at the University of Southern California, where she earned her master's in marriage, family, and children counseling. Ms. Wen is currently the therapist, supervisor, and wellness and Chinese ISM program coordinator at Pacific Clinics. Before she came to Pacific Clinics, Ms. Wen was a consultant and adjunct professor at the University of the West. She has been an advocate and continues to volunteer with NAMI, California. At this time, it is my pleasure to turn it over to Dr. Trang Hoang. are ready to begin with the introductions and moving forward with the webinar. So give us just a minute as we get Dr. Hoang ready to do the presentation.
Okay.
Okay, we can hear you now. Go ahead.
Can you hear? Good morning. My name is Dr. Trang Hoang with SSG Alliance. I want to thank CIMH for involving us in this collaborative effort. We're privileged to be here to share our learning experiences with our API communities in Los Angeles. And we are the last of the webinar series of the different ethnic populations. So we're very pleased to be able to share with us our work experience. May, if I could have the slide. Okay. Okay, there you go. I wanted to note that this is a collaboration of partners in the Asian Pacific Policy and Planning Council. Here in Los Angeles, we work collaboratively across the county among the different API communities, and it involved the APCON involves many different agencies who are serving the API population. So this particular webinar series, we're very pleased to be presenting to you 3 different components of mental health services with our APIs. Today we will be looking at outreach and engagement strategies. We're using learning experiences from the integrated service model. So the 4 presenters will be talking about specific strategies to address challenges and barriers that relates to outreach and engagement with populations that have traditionally been marginalized or hard to reach or have certain cultural variations that need extra consideration in order to engage within the mental health service system. On April 16th, we will talk about direct service across the lifespan. You will get case examples. We'll have our psychiatrists talk about the DSM-5 and the cultural context. We also will have case from family work with children and older adults. And April 30th, we will have an example of the community-defined practice. We look at the development and implementation of community practice that comes from our API communities, the intricacies of involving developers, funders, as well as becoming and using a grassroots organic approach to mental health services. So we want to call your attention to participate in all of our webinars. For today, I will start us with a little bit of overview of the Asian Pacific Islander communities. So as you know, we are one of the fastest growing population in the U.S. at the rate of 46%. U.S. Census Bureau data shows us between 2000 to 2010, we've been increasing across the U.S. There are 19.6 million of the APIs in the U.S. And here in California, our own state, we have a high percentage of APIs. And here in Los Angeles, there's a good 2.1 million of APIs in Los Angeles. So just to give you a quick overview of the diversity of our communities, I wanted to share with you some data from the Asian Americans Advancing Justice that came out in 2013. Now I want to call your attention to please use the data from the source. There's a lot more data about health disparities and about the diversity within our communities. So this is just an example to show you the different languages and the different ethnic breakdown within our API communities. So when we talk about API, we are talking about Chinese, Koreans, Japanese, different Laotian, and the Pacific Islanders from Singapore, from Samoa. So if you look at just this basic list, you can see the diversity in terms of our language differences and as well as the ethnic breakdown, the ethnic makeup of our communities. So within the context of mental health service, bear in mind that any type of services would have to accommodate the different levels of cultural knowledge as well as linguistic capability. So this is the type of context that we work with in Los Angeles when we talk about mental health services. So as we go through the webinars, you will hear examples from different communities in doing outreach and thinking about the different cultural variations as well as the specific of the geographic breakdown as well as immigration patterns that impact concepts of mental health and service utilization. You'll hear examples about the Cambodian community and how they think about accessing service. You'll hear examples of Samoans about how they conceptualize family and service within that context of the culture. There's some other diversity when we look at different API communities. It's not only just ethnicity or language, but if you look at education, so if just on an aggregate level, you look at all in terms of education, if you look at individuals with, this is from the Census Bureau, individuals with the BA degree or higher, if you look at the Pacific Islander, they have one of the lower rate compared to some of the other Asian populations and the other Asians in the API communities. And poverty level, whereas in poverty level, they show a much higher rate than the overall Asian population. Health insurance. Here in California, we have our focus on getting individuals involved and enrolled in health insurance. But if you look at health insurance, even with health insurance level status, our Pacific Islander population shows a higher rate of having no access to health insurance. So these are some of the just sort of examples of some sort of variations within our API communities, not just on language or background. Median household income. So I just wanted to highlight some just basic numbers that shows you there are very large variations among our API community. If you look at the difference between the Bangladeshi, even if we think about South Asians, we think of lumping the group into one component, one larger group. But even within the South Asian communities, there's variation between Bangladeshi versus Asian Indian or Pakistani. And then, of course, Pacific Islanders and other Asians, Chinese Americans or Vietnamese Americans. So if you just look at some basic numbers, you could see there are wide differences among the different communities. Here in Los Angeles, I just wanted to also highlight some of our sort of specific needs. This is the show of the percentage of language limited English proficiency within our communities, and it gives you at a glance and a view of the percentage of our APIs who still need English supported, language supported services. And if you look at the Burmese, the Taiwanese, some of the more recent communities. Okay. So this highlights some of the diversity within our community. And here's another example in terms of looking at health status among API communities. So there are variations in terms of different causes of disease, causes of death. There's wide variations between the Cambodians and the Filipinos in terms of which are the more prevalent diseases, if you will. And when we think about outreach and engagement, this is all part and parcel of the concept of wellness and health, as well as mental health. So we just wanted to call your attention to some of these specific areas. Now, each of the ISM will be talking specifically about integrated service and how they incorporate different concepts of health, behavioral health, mental health, and wellness within the community, the specific communities. So we will move into examples, if you will, from 4 different communities to address very specific components of utilizing these data as well as knowledge about the culture in order to maximize engagement into service. And then on the 16th, you will also hear about how different immigration patterns and different historical contexts shape the conceptualization of mental health. This is just a little bit more data about utilization here in Los Angeles. I'm just going to leave some of this data with you. You do have access to the PowerPoint. And I also want to call your attention, we also have more handout and reading materials to be distributed. So we will make that available through this CIMH. So I wanted to transition to our next speaker.
So good morning, everyone. My name is Mariko Kahn. I'm the Executive Director of Pacific Asian Counseling Services. And it's my pleasure this morning to talk a little bit about the background as to how these 4 ISMs, and I'll tell you what that means later, were funded and what our goals are. So you may not know this, but there are a lot of millionaires in California. And in 2004, the voters of California approved Proposition 63. Which levied a 1% income tax on those individuals whose income was above $1 million. Unfortunately, I'm not in that group. This became known as the Mental Health Service Act, or MHSA, and it had 5 components. And one of those components was the Innovation Plan, which was to develop creative ways to increase a community's access to integrated care, overcome stigma, educate the community about mental health, and overcome disparity. In 2010, the Los Angeles County DMH issued an RFP for this plan called Innovation, and one of those plans was called the Community Designated Integrated Service Management Model, quite a mouthful, so we call it ISM. And the ISM funded 14 different ethnic communities, and it's a 3-year contract. So I'll skip this next paragraph, you can read it later, but of the 14, 4 of the ISMs were designated for API communities. And the ones that were selected, because it was a competitive bid process, was Cambodian, Chinese, Korean, and Samoan. So you're going to hear from each of us throughout this. The API ISMs were funded for approximately $607,000 from the MHSA. But when we leveraged it against Medi-Cal, it really became a contract for about $1.1 million. The parameters for the clients who could be enrolled in the ISM was, first of all, they must meet medical necessity for specialty mental health services. That means they must have a mental illness. And then they must either have a medical condition and or a substance abuse issue. So that required our ISMs to be partnered with a federally qualified health center. Each ISM had to do outreach to at least 160 people and enroll 54 unduplicated clients. And of those, 60% must be indigent, although the clients could come from any age category. What was great about this ISM funding is we could provide support services such as transportation, linkages, referrals, wellness activities, and follow-up. And even better, we were allowed and encouraged to use a holistic approach, which would allow for the inclusion of non-traditional, meaning non-Western, because they were traditional within our cultures, healing practices such as acupuncture, massage, and spiritual ceremonies. So what we found is each API ISM ended up being structured differently because it depended on the partners that we incorporated in our proposal. And during the first year, in fiscal year 12-13, we all really struggled because we found that the stigma associated with mental illness was so much higher than we had anticipated. And these are from agencies who are very much involved in their communities. So one of the learning processes, and this is innovation, was to develop our own individualized and unique strategies for outreach and engagement. I just wanted to show you this because this chart shows you the disparity that we had to overcome. The first year, to get 8 enrolled Samoan clients, the Samoan partners had to make 3,500 contacts. The Korean ISM, to enroll 26, had 3,000. The Chinese ISM, which was a little bit different because their FQHC was the lead, had 285 contacts to enroll 28. And the Cambodian ISM had 3,832 contacts to enroll 66. So you can see that disparity is alive and well. Some of the barriers we encountered were, of course, just the public health system with all of its regulations. And we want to thank the LA DMH because they really communicated with us constantly so that we could get through many of these administrative barriers. In addition, we found that integrating 3 service systems, which are the behavioral, medical, and substance abuse systems, presented their own challenges. And integrating was not as easy as just being co-located or sharing the same client. We found that the levels of confidentiality were very difficult, and we're still struggling with that sort of thing. So each API ISM at this point is going to share their challenges and their models of engagement strategies, and I think you will enjoy each story. So I'm now going to turn this over to the Chinese ISM.
Thank you, Mariko. Hi, my name is Hoang. I am a marriage and family therapist and program coordinator for Chinese ISM program. Thank you, CIMH, and thank you, Trang, for inviting me here. It's my pleasure to be with all of you, my API partners and fellow professionals participating in this webinar. The topic of my presentation today is strategies learned from Chinese ISM program. First off, geographic location. Chinese ISM program is offered at the city of Rosemead and El Monte. Our service covers the San Gabriel Valley area, LA County Service Area 3. When waves of Chinese immigrants settled in the San Gabriel Valley in the 1980s, the area became the suburban Chinatown. Despite booms and economic development in this vibrant community with a concentrated Chinese population, and the recent preconceptions about Chinese immigrants being rich and affluent, we observed that oftentimes mainstream society and organizations in San Gabriel Valley, including local business in LA County, failed to recognize the mental health needs of Chinese American immigrants. We observed disparity in mental health services and social resources among the Chinese immigrants who are often unserved, underserved, or inappropriately served. More on mental health disparity. Throughout outreach and engagement, it was unusual for us to visit households with a mentally ill 37 years old Chinese American adult living with elderly parents. The individual had never received mental health treatment, never seen a family doctor for years, and never known of government support. It was not uncommon for us to learn about a Chinese immigrant who became unemployed after working in the U.S. for 20 years, coping with physical pain, high cholesterol, and presented with suicidal thoughts. We were able to serve or make referrals for just a small portion of the people we outreach to, but we believe that there are a large number of individuals and families we are yet to be reached, and helped in our community. Who are we? We are the Chinese ISM program, a collaborative partnership between Asian Pacific Family Center and Asian Pacific Healthcare Venture. We are like twin brothers or twin sisters ever since we planned to integrate our service together. APFC have proudly served the community for 28 years, providing outpatient and field-based clinical services to the children, youth, adults, and older adults in the area of mental health. CV is a nonprofit community healthcare clinic. Like APFC, APHCV offers services in multiple languages. APHCV also works to maximize patients' insurance plan and offer financial arrangement for clients who may require assistance with medical, health, and wellness expenses. In terms of staffing, all of our staff are of Chinese descent, culturally and linguistically competent and responsive. Our staff include physicians and nurses, mental health therapists, case manager, team coordinator and program staff, as well as health navigator. I will talk about health navigator later. We provide services in Mandarin, Cantonese, and English. About treatment services, Chinese ISM program offer primary health care services and referral to specialty health care. We offer mental health treatment including counseling and psychiatric treatment, medication, group rehab, and substance abuse treatment program and referrals. In addition to the services usually offered by medical care providers and mental health treatment providers, we also feature some of the services unique to our program. We provide health and navigation program and health and wellness groups and education classes. We also offer alternative treatment services including acupuncture and Chinese medicine treatment to our clients. Chinese ISM enrollment data from July 2013 to 2014. Let's look at our table on the slide first. Through our outreach and engagement, we were able to enroll 52 clients and provide integrative services to them, and we aim at meeting the goal of serving 54 clients in this year. I have included 3 examples of our recent outreach and engagement activities. For example, we partner with American Heart Association, Lion Clubs, and Union Bank to organize Health and Wellness Expo. Let me share with you some of the data on the population we serve. The age range of our client is between 18 to 60, Chinese American with low income or no income, presented with mental health and physical health needs and or substance abuse problems. We're currently serving 3 clients with substance abuse or alcohol abuse problems. 50% of the people we serve have limited English proficiency. In terms of immigration generations, 85% of our population are first-generation Chinese immigrants. Some are recent immigrants, and some may have been in the U.S. for more than 20 years. 15% of our population are either born here or came to the U.S. at a young age. In terms of gender, I would like to draw your attention to this data. And I want to point out that we serve more males than females currently, with a rate of 60 versus 40%. This number challenges the myth of Chinese American males being emotionally restrained and never talk about feelings. One factor that may help explain this number was that we have both male and female professionals who are quite sensitive and competent in engaging clients. Currently, we are also serving 1 client from the LGBT community. After sharing with you about who we are and what we do, let me present to you 8 strategies that we learned from running Chinese ISM program, and they are really useful, so follow me closely. Strategy number 1, as I showed earlier about the population we serve, many of the Chinese American immigrants have limited language proficiency. We often hear from mainstream media, internet, radio, or in the political dialogue, people including Chinese American asking this question, why don't they learn English? Why don't they? To help answer this question, I recommend our audience checking out this book by Lucy Zhe with exactly the same question. Back to our ISM program, in order for us to better serve our population, we require our staff to be able to speak Cantonese or Mandarin in addition to English. These are the 2 major dialects in the Chinese culture. On the transportation support, many of our clients who suffer from severe mental illness are either unable to drive or get too anxious to use public transportation. Our health navigators will provide transportation support if clients need help to get to psychiatrist or doctor's appointment. They will also help with interpretation if there's no professional interpreters available on site. Let me share with you strategy 2, financial stability and wellness. According to California Reducing Disparities Project, API Population Report in 2013, being financially stable is one of the 6 definitions of wellness among API community. In the Chinese ISM program workflow, financial screening comes first, and we as a team are committed to address our clients' need for financial support and wellness throughout engagement and treatment process. Strategy 3, engaging families. Our program encourages family support and works with family members whenever possible. This just fits our cultural value of being family-oriented and interconnected. I just want to highlight one strategy that our program staff mentioned. When approaching potential Chinese American clients, instead of directly asking people, do you need help or do you need mental health counseling? We find it more sensitive to ask indirectly. If your friend, family, or loved ones need help or support, please come to our center or dial this number. Strategy number 4, partnership with family doctors and community organizations to build trust. In the Chinese community, many people really trust their family doctors or physicians, but they are not familiar with mental health clinics. Partnering with family doctors and having them refer clients to mental health treatment will increase the likelihood of clients showing up at our door. In the next slide, you will see how and where we identify and engage our potential clients into Chinese ISM. Yes, we do have a lot of information listed here. I'm not going into details, but what I'm going to do is to highlight that our clinic office and phone numbers are really the hub of inquiries for mental health and physical health services, thanks to our good reputation in community. In addition, as you see in the middle area, highlighted Christian Herald and Tzu Buddhist Foundation, and also Xilai Temple and Chinatown Service Center. These are places where we identify our potential clients or our partners refer clients over to our center. Strategy number 5, use of group modality to engage potential clients. We use Tai Chi group, arts and craft, karaoke group, as well as Cantonese support and recovery group as point of entry. Instead of inviting potential clients to counseling services, we ask some of our potential clients if you are interested in joining these groups first. From there, people learn and share life skills, and they start to make friends. They may feel more attracted to our program and ask to join. Group modalities really work well for Chinese Americans who came from a similar background, geographically, in terms of language, dialect, etc. Strategy number 6, health education. Education is highly valued in the Chinese culture. We run a monthly Healthy Happy Meal class and created a friendly environment where people cook together and make healthy foods such as dumplings, sushi, and spring rolls. Sharing food brings together people, and it is a huge part of Chinese culture. We also utilize weekly health education workshops to address prevalent API health conditions. That is high blood pressure, diabetes, arthritis, cancer, and pain. Culturally competent acupuncturists and nutritionists would lecture on alternative healing and healthy style. For example, they introduce traditional Chinese soup and ingredients to the group. And I learned from one class that laughing out loud and often is healthy for our kidney according to theory of Chinese medicine. At this moment, I want to laugh out loud. Strategy number 7, matching clients' preferred learning style. Due to limits of time, I'm going to skip strategy number 7. Basically, we recommend providers to pay close attention to and match clients' preferred learning styles during outreach and treatment process. Strategy number 8, health navigation and peer support. What is health navigation? Health navigation is a project designed to train mental health peers, paraprofessionals, and professionals to help mental health consumers or consumers with mental health issues navigate the physical healthcare system, make lifestyle changes, and improve overall health. It is a pilot project conducted by a team from the USC School of Social Work in collaboration with Pacific Clinics. This project has trained many navigators at Pacific Clinics and LA County Department of Mental Health. Why do we need health navigation? People with severe mental illness have a lifespan that is 20 to 25 years shorter than the general population in the U.S. Research has demonstrated that people with chronic mental illness often use care inappropriately. Some simply do not seek out medical care, and some may routinely use the emergency room instead of outpatient care. For more information, please review the website at www.healthnavigation.org. In terms of the function of Health Navigator and peers, a few words on the function and roles. Health Navigators conduct outreach and engagement services and coordinate with a team to help enroll ISM clients. As I mentioned earlier, navigators provide transportation support and linkage for clients between physical health and mental health clinics, and substance abuse treatment programs such as ADAP as well. They are personal coaches also on the healthy lifestyle. Our navigators also come from a background of lived experience of mental illness, and they are also peers. Health navigators, through their work and learning at Chinese ISM program, they have become experts on healthcare resources such as local dentists and Chinese acupuncturists. I would like to highlight this success story. And this story was told from the perspective of our health navigator, Mr. Boy Wong, who had been working with Mr. L. Mr. L suffered from depression, and he had neglected his own health for years. Here's the story. With the health navigation training, I learned how to coach our consumers to get a better quality of life. When I first engaged this consumer, Mr. L, I was surprised to learn he had not seen a primary care physician for 10 years. I took him to see a doctor who had me accompany him to the ER immediately. Mr. L was not aware he had diabetes, and because of his poor health, one of his toes had to be amputated. When released from the hospital, Mr. L continued to eat unhealthy foods, but after 3 months of continued coaching, he made significant progress. He now measures his blood sugar level 3 times a day and records the results. He brings his records to his doctor's appointment. He is now eating healthier food, and he has started walking 10 to 15 minutes per day despite his amputated toe. Initially, when Mr. L was released from hospital, he continued to eat a lot of unhealthy and fatty food. Our health navigator took him to a local market and educated him on the healthy food and purchased healthy food along with him. Our navigator also kept reminding Mr. L of his medical appointments and providing transportation support whenever possible. In addition, our navigator visited Mr. L and walked with him around his neighborhood to help him develop a good habit of exercising. Now, Mr. L had replaced white rice with brown rice, and he eats more vegetable and fruit. He had not touched instant noodles for more than a month. If you think about someone or yourself who have developed a certain lifestyle for 10 years, a change of such made within 3 months was rather significant. To sum up, I share with you 8 strategies we learned from developing Chinese ISM program. Language and transportation support, as well as financial wellness, are essential. We engage both families and community partners. We use group modality and health education to our advantage. I highlighted at the end our health navigation and peer support program. With my presentation, I'm hoping to attract more attention, interest, and discussion on engaging and serving the Chinese American in our community. Thank you. Now I'm going to turn the mic to Grace.
Thank you. Good morning. My name is Grace Park from the Koreatown Youth and Community Center, and I represent the Korean ISM. According to the 2010 Census Bureau, there are currently 505,000 Koreans residing in California. Of these Koreans in California, about 70% are foreign-born. Again, of the Koreans in California, almost 50% have limited English proficiency. When it comes to immigration, Korean immigration to the United States, there are a number of difficulties that Koreans encounter as they immigrate. One thing that we know about Koreans is a lot of Korean immigrants have a difficult time transitioning from white-collar professional positions in Korea, and as they come to the U.S., they aren't able to remain in those professions, so they often end up doing more blue-collar work. Sometimes we see a lot of Koreans who are self-employed or who work in small businesses. As a result of this, there's a large number of Korean Americans who don't have health insurance. We know that about 1 in 4 Korean Americans don't have health insurance. For Koreans, again, who immigrate to the U.S., there are generational differences. We categorize different generations as first generation, who are immigrate, they're Korean, they immigrate to the U.S. as adults. Then you have second generation, which are the children of immigrants who are born in the U.S. In between, we have something that we call 1.5 generation, and these are folks who immigrate as children between the ages of 6 through 12, and they often feel, they can either lean towards being more first generation, more towards second generation, or feeling kind of stuck in between. There can sometimes be conflict between the generations, and it's something to know about the Korean American population. For all Korean Americans, there's various rates of acculturation. So it's, again, good to know that there's diversity amongst the Korean American immigration population. For Korean Americans, the church is really the central institution. There are, of Korean Americans, there are about 80% who identify as Christian, and that's both Protestant and Catholic. Historically, American missionaries arrived in Korea in the late 1800s, and at that time Christianity expanded quite rapidly in Korea. From the 1970s to 1990s, there was a large wave of immigration of Koreans to the U.S., and as they immigrated and settled in the United States, wherever they landed, they would establish churches, and that would become their kind of central institution. Even within Korean churches here in the U.S., it's important to note that there are generational differences. There's a first-generation Korean-speaking ministry, and there's also second-generation English-speaking ministries, which can either be, they can sometimes become independent of their parent church, or they can remain within a first-generation Korean-speaking church. These are just some barriers that Korean Americans face in terms of accessing mental health services. In some instances, the church itself can be a barrier, depending on the church, to seeking mental health services. There are issues of shame and stigma and saving face, particularly for the family. We know that Koreans often delay help seeking until they're at a crisis point, and that applies to both physical health and mental health. For the Korean American community, there can be a lack of basic understanding regarding mental health in general and kind of where to access services. Practically, there are language barriers. There's a lack of culturally appropriate treatment providers, and again, the lack of health insurance often keeps Korean Americans away from the mental health system. There can be a belief amongst Korean Americans that any mental health issue could be overcome just by exercising your own willpower. And again, that will keep people away from seeking help. So again, I represent the Korean ISM, and the Korean ISM consists of 7 different partner agencies. We have 4 mental health providers who target different age groups. We have a community health partner and a substance abuse partner. Additionally, we partnered with a faith-based nonprofit to really target outreach. Again, as we developed this collaborative and identified partners, we really focused on providers who were already well established in the Korean American community here in Los Angeles. I'm going to focus mostly on outreach, education, and engagement, and we call that OEE. Just some definitions for you. Outreach is when we inform individuals of our ISM services. Education is when we go out into the community and talk about mental health, and substance abuse with the purpose of increasing awareness and decreasing stigma. And finally, engagement is when we're able to work one-on-one with a potential client to build some trust with them and in hopes that they would agree to receive services. So again, we partnered with a faith-based organization who were solely going to be responsible for the OEE for the Korean ISM. And we identified a partner who was well established. They have a strong network amongst the Korean Christian community. The organization we partnered with is called YNOT. And YNOT staff members, the folks that they hire, have educationally a background in both mental health and theology, so they were ideal who we would want to partner with for our ISM. Our role as the lead in the program was to train our partners at YNOT regarding the specific eligibility requirements for ISM, what clients needed to know in terms of their enrollment, as well as training them in county documentation. So as we started our OEE, our outreach, education, and engagement, we did things kind of, typically that you may expect in terms of an outreach plan. We staffed booths at community events. We worked with ethnic media. We did interviews to try to get the word out. We did educational workshops, topics such as parenting, mental health, and premarital. We also created brochures and distributed them widely to get the word out. I just wanted to share with you some of the presentation material that YNOT used when they went out to the community. So they really focused on the overlap of mind, body, and spirit, and how that all of those components need to be contribute to like a healthy whole person. This is again part of YNOT's presentation material. As they tied together mind, body, and spirit, they highlighted that for each component there would be a different professional that would address the various issues. In addition to YNOT, we also contracted with the clergy. So we hired a pastor. He's an ordained pastor who works as a chaplain in a hospital. And he works in a mainstream hospital as opposed to one of our smaller Korean-specific clinics. But he works in a large hospital that happens to have a large number of Korean patients who go to that hospital. It was great to partner with this clergy member because of the importance of the church in the Korean community. We know that clergy are really seen as leaders and authority figures for Korean American. In hiring this individual, it was beneficial to us that he was not affiliated with a specific church, so that he could kind of have a broader audience. And his outreach was targeted towards his peer group, which were other Korean clergy, so that again, as leaders, they could talk to their church members about being open to mental health services. He also was able to engage potential clients in the hospital, as clients, patients, or family members would be meeting with him to deal with physical health issues. Outside of kind of typical outreach activities that you may already be familiar with, I just wanted to highlight some less typical and creative things that we tried in our outreach efforts. The first thing is a warm handoff, and that comes from the integrative aspects of our work. So our YNOT staff would first engage a potential client or family in their offices, and once the client was willing to receive the referral for mental health services, the receiving therapist would join YNOT at their office so that they could introduce the potential client to the new therapist in a safe space, and that the potential client would feel comfortable with the transition from YNOT as the outreach team to the receiving therapist to open the case. Our substance abuse provider is currently running family support groups, and that's targeting family members of substance abusers in hopes of eventually helping the family member who's using to enroll in services. YNOT has also run a couple clubs or groups. They had book clubs, and that was age specific. And they also had a jewelry making club, and as they would bring individuals together, they would talk about stress and stress relief and health and healing. And again, that was a way to engage the community and identify potential clients. We've also done outreach to a local driving school, and this is a Korean driving school where folks can go if they've had a DUI and they may have to take a class in hopes of reaching some potential clients there. We've also gone to Korean supermarkets and even to a local McDonald's where there are a large amount of elderly Korean men who spend their time. So just looking kind of at initial, evaluating the effectiveness of our OEE efforts, we see that I have a list here of what has been unsuccessful and what has been successful. So to date, we have outreached to, again, we started this program in May of 2012. We've outreached to about 7,000 individuals. And again, that just reiterates stigma is indeed strong. We have to do lots of outreach to enroll 54 of our, required slots. And it did take some time. It did take time to kind of ramp up to get to our, to meet our goal of enrolling 54 clients. This is our current enrollment data, and it just shows a breakdown of who enrolled. If we look at age, we have the majority of our clients are from the adult population. We have a very small percentage of child and TAY, and TAY stands for transitional age youth. So that age group is 0 to 25. For adults, 26 to 59, and older adults is 60 plus. Our gender breakdown is primarily, we have more females than males. For insurance, we have a large number of uninsured folks who have Medicaid. And again, that was one of the requirements of ISM, which is that we are serving the indigent or uninsured population, which has been a great asset of this program. We know that we have lots of folks who are uninsured, and without this program would have had a difficult time identifying resources and services. In terms of our secondary diagnosis, we see that a majority of our clients are coming in with a secondary as physical health as opposed to substance abuse. This slide shows, so we had our enrolled, we had requirements per slot by age group, and we see that it was easy to enroll adults in that we're over the 100% requirement. Older adults were close to being full, but where we've really struggled in the ISM is the child and TAY population, where only 30% of our required slots have been filled. So some things that we've learned so far in terms from the ISM is that, again, stigma continues to be significant. We've learned from our work with the Korean community that physical health really comes first. One requirement of ISM is that you have to change your primary care provider to our health partner, and there's been a lot of difficulty there with folks who would prefer to stay with their primary care provider. In terms of alcohol, we've learned that the Korean community will often downplay any alcohol-related problems, and that has been difficult in terms of, again, engaging the substance abuse population. And there has been, another barrier, some resistance regarding working in a rigid government system. Again, we're county contracted, so we have paperwork and forms that need to be signed, so there has been a barrier there. Some recommendations for any potential outreach to the Korean community. The engagement piece has been particularly helpful, but it takes time. So if you are attempting to engage the Korean community, to have that time to be able to build trust with the community. Definitely working with faith-based partners and any work with the Korean community, partnership with the faith-based partners is going to be key. Again, because of the strong mind-body connection, we recommend partnering with physical health. Knowing who in your community, who in your Korean community, in your local Korean community is established in terms of providing physical health services, and including traditional health, so including partnering with acupuncturists on the front end to try to find clients to refer. Again, something that we've learned and that we really recommend is to be strategic regarding targeting different age groups, different generation groups, knowing those differences, knowing how you're going to do outreach to transitional age youth versus the older adult community, for example. Okay, thank you very much, and I'm going to hand this over to the next speaker.
Thank you. I'm back. This is Trang Hoang again. I'm happy to be able to report on our work with the Samoan ISM. If you've already noticed, I'm hoping that you already find themes among the ISM, and you will see some of the themes with among all of our ISM. Sort of the whole focus of integrated service, the connection to the health partners, as well as different generations and our immigration pattern, and to be accounting for those sort of factors. So our Samoan ISM includes partners, which is the Office of Samoan Affairs, the Samoan National Nurses Association, and the South Bay Families Health Center, and SSG Alliance. So our work with the Samoan community includes the Samoan population in LA, which is an urban context. So if I want to call your attention a little to sort of the notion of the within the Samoan community, there's this notion of American Samoa, and Samoa in the home country, and even with immigration, with migration, there's still sort of that connection, if not physical, then at least psychological connection to the island. So bear in mind that when we talk about Samoan community here in Los Angeles, there are remnants and there's connection to families who are still in Samoa. And later on, I'll talk a little bit about how some of our outreach even is mentioned in the island. It's like, oh yes, you're that ISM. So just bear in mind that that's sort of part of the characteristic of the Samoan community. It is still quite a bit of link to families to Samoa. So our mission is to look at integrated care in a diverse urban environment. Now, our population is spread out all over LA County. So the work that we do is not limited to a particular, what we call service area, as is sort of traditionally within the mental health system. The system tends to locate in one one of the things we're finding is that in order to reach out to our communities, we have to go across these little neighborhoods and medical homes. We do have to conceptualize our reach across all of LA County and sometimes cross county line. So there are some of the barriers from the beginning with funding source in terms of, well, this is funded in LA County and we can't do, say, an outreach in Orange County, although there are quite a bit of connection with the Samoan community in Orange County. So there's some of those constraints within the urban environment, within this, California realities that we work with. And one of our mission is to look at the specific needs and approaches of the Samoan communities. And that requires us to really reach out into the communities and asking different generations, asking for needs and issues from different generations, not just sort of the representatives, if you will, of the community. So that's been one of our focus in outreach, is not just to go to the churches or the faith-based or to the established organizations, but to try to do outreach with youth communities, groups in the colleges and also high schools and other levels of populations within the community. More and more, one of the flavor of our Samoan ISM is to really think about capacity building, really focus on how the community defines itself and how the community builds a capacity to look at service delivery. So that's been one of the focus within our ISM in the last 2 years and moving forward into the future. We also are looking at the mix of formal and formal and non-traditional providers, as well as models of service, if you will. And again, that's a theme that you are going to see across all the ISM, and the Cambodian ISM will really highlight more of that as well. So for us, and of course, integration of health, mental health, substance abuse. So that's sort of the mission, if you will, the mandate that we were given at the beginning of this ISM journey. And we call it a journey because we don't find that there's an endpoint, even though funding is going to stop. But we anticipate that our work has far-reaching implication, and also we hope, we idealists that we are, we hope that we are making changes, we're making headroads into both our Samoan communities as well as within the DMH communities about conceptualization that's going to have far-reaching impact beyond the 4-year funding, beyond the funding of the ISM. So I'm just going to put my soapbox out there that we tend to think of our work as really the beginning point to the needs of communities, as well as to really look at how do we change the way we think about service delivery, and how do we change the way we conceptualize outreach. So much of my presentation is going to be really about conceptualization and less of sort of the exact numbers. So again, a theme that you've seen throughout is health disparities. I'm including these slides, which are developed by our partner, Sana, because I think it's really highlighting some of the concerns that our partners are facing. Because our partners don't just work with us in the mental health community. They do a lot of parenting class and health education and outreach in their own right within their communities, and they've been around for a long time. So this is just sort of a joint collaborative journey that they travel with us, if you will. But the concerns has been ongoing within the Samoan community. So there's concern about obesity, about cardiovascular disease, diabetes, cancer, and some of these are sort of statistics, if you will, that highlight why we have concerns about health habits and eating habits and diet, and why our work, albeit it's mental health focus, which is about feelings and about daily activities, but it is also linked to the way of life. And so this is one of the things that we've learned from our partners that I really want to highlight with you is, forgive me if I don't say this correctly, Samoa, the Samoan way of life. So really, if you think about wellness and mental health, it has to be coached within what we call the way of life. So there's culture, there's faith, the tie, and there's a tie that binds the two together. And that really translates into how we go about the world, whether it's what we do every day in our daily activities, or whether we're going to sign up for a mental health service, or we're going to sign up for why should I sign up to receive your service? Is that part of within sort of my understanding of what is wellness? So when we conceptualize outreach, we really have to coach our description, if you will, of our services within this cultural and this faith practice. And this is what we call the way of life. And within this way of life, I'm just going to lay out for you some of these teaching points, if you will, that our partners have been working with us and developing and teaching us and others about really the way to think about it, and then hopefully to give you sort of a framework, if you will, to think about outreach and engagement. So bear with me if I'm sort of saying on a more esoteric level. So there's this Samoan way of life, and within this way of life, we also have to reconceptualize family. So for the Samoan family, it's a very branchy tree, lots and lots of connections and leaves and twigs everywhere. It's not just one trunk with a son and a daughter, as sort of that nuclear family that we know from other cultures. So with the Samoan community, when you say family, that's my second cousin removed. And that's very, very close to me. That's my second cousin, and he's a brother to me. And so therefore, what you have to say to me, it can be said in front of my second cousin. So it's that conceptualization of family that actually is, we find in our work, has been very instrumental in getting people into service. So I'll come back to that. But really, if you will, when you think about working with Samoan families, we have to broaden our context to include family, and also sometimes identify sort of adopted family. So yeah, we're not related by blood, but we are somewhat related, or that we're sort of village level related. And that's it's part of my clan, and so therefore just as close to me as if it were my brother. And therefore, when we do outreach or when we do treatment planning, we have to think about that within that concept. All right. And then still within the family structure, there's also the village, or the village structure, which includes elders and pastor or chief. So when we work with Samoan communities and families, we're finding that there is definite hierarchies. There is those intergenerational factors that Grace had talked about with Korean community, which is there is definite respect, which is important, and then you have to approach the elders, and then the youth would have their own sort of level of communication, if you will. So there is some level of hierarchy, and pastors and chiefs are part and parcel of that hierarchy. And so when we do outreach and engagement, we need to respect that hierarchy and conceptualize how we do our introduction and our description, utilizing some of the strengths of that hierarchy, and maybe sometimes do use the pastor as an entry point to help connect to this other family. Or sometimes starting with the youth and the children and understanding the issues, but highlighting some of that and explaining that to the parents so that they can understand better about sort of the acculturation process that these youth have to deal with within the U.S. So family structure is part and parcel of our conceptualization of outreach. So at this point, what I'd like to do is sort of present this from the 2 years we've been working with this notion that we've learned. And this probably echoes some of the other communities in the U.S. We're learning from the Jewish community and their and the understanding of trauma, and also the Native American or the African American communities in terms of understanding trauma within the historical and cultural context. So in our work with the SEMO and ISM, we're realizing that when we present problems, or whether it's substance abuse or eating or diabetes or trauma, we really have to present it within the historical and cultural context. So if the community accepts that yes, we've got some substance abuse issues going on, or yes, we have trauma associated with immigration or trauma within the family, whether it's domestic violence or any other problem areas, if the community recognizes it, then it's okay for the family to be experiencing that, because it's okay. It's part of the community. The community has accepted that, yes, within our community we have some of these issues that need to be addressed. So once a community accepts that, then there's less shame and stigma. So I know that in when we talk about engagement and outreach, we talk a lot about shame reduction or stigma reduction. And of course the question is, well, how do we do that? Well, really for us, what we're understanding is that shame and stigma isn't a single entity. It really is sort of coached within the cultural understanding of wellness and illness. And so therefore, if within the cultural context of the community, here's wellness, here's illness, and it all sort of interrelated, then the family can accept that and say, it's okay for my family to have some of these problems. And if my family is okay with it, then it's okay for the self. It's okay for me to have some of these problems. So therefore, I can talk to Grace, who is the mental health staff, who's going to talk to me a little bit about substance abuse, or like how much of my drinking is a problem and how much of my drinking is not a problem. So it's got to be coached within that community context. And so now, if you can bear with me, I'd like to tie that a little bit into our social work context, or our notion of stages of change. So one of the things we're finding with engagement and outreach is we really have to think about the stage of change for the self and the family and the community. So the community, so stage of change, we're looking at pre-contemplation. So if the community is still at the pre-contemplation level, which is, well, we don't really see how much, we don't have domestic violence in our community. If they're at that level, doesn't matter how much information we give, they're not ready. So at that stage, so much of outreach engagement has to be awareness stage, which is, okay, well, let's talk about substance abuse. What does that mean? What does it look like? What does it look like from what does it mean to you? So we're not throwing information, but we're engaging people in discussion. And some of this is at a larger level, which is the fair level, or some of the larger context of just, after church kind of activities. So it's just this sort of general awareness. And then we, in the ISM, we do some media spots in some own media, because that's part of that awareness raising. So once people move into this sort of contemplation, recognizing that, yes, maybe we could look at some of these issues, that's when we do the information giving. So then you could do the stress management, the bullying. So our partners do some workshops in the schools on bullying, on stress management. They do health education, parenting class, or just sort of parenting workshops, if you will. So that's at the information giving level. So we're beginning to sort of coach our outreach and engagement strategies along these continuum of stage of change. So then we could provide some more information, the impact of problem drinking, the impact of diet and nutrition. And then once people move into sort of the planning stage, even then they're not ready to sign papers. And this is what we find the barrier, if you will, of DMH paperwork, because until we have people sign the consent for service, we really can't say this is an enrolled client. However, they're not quite ready to sign the paperwork. They're still in the planning stage. They're not at the action stage yet. So there's still a bit of that trust I'm just meeting with you. So my cousin told me that, I should meet with you because you may be able to support me. So I'm just meeting with you. I'm not ready to sign my paper because I'm still at that sort of planning stage. I'm thinking about it, right? So therefore, there's always a balance, and my partners here in the room are nodding because they all find out within the ISM. That's where flexibility comes in. So again, the theme is across these communities. When we talk about engagement, we're talking lengthy engagement because we're talking about moving people from that planning stage to action stage. And action stage is when I actually sign paperwork to to consent for your treatment, whether it's health or mental health. And that's really, I'm at the point where I am willing, I'm doing something for my change. Throughout all of this process, I want to highlight the issue of trust with the Samoan community. So we talk about building trust. Now, trust within the Samoan community with the faith-based community, which is the different Samoan churches, similar to what Grace talked about with the Korean community, which is their generational churches as well. So there's the churches sort of more geared towards certain group within the Samoan community, and then there's some more youth-oriented churches. And so when we build trust, we have to be aware of the different level of trust with these different level of the CBO, what we call community-based organization. They're very grassroots and community-based, which is fantastic because they really are at the pulse of the community. They know the pulse of the community needs. However, we also have to be aware of the different level of trust between different generations with different pastors or different churches. And so getting people moving from planning to action takes awareness of that level of trust and knowing where they trust and who they trust, and how do we maximize those community connections, those sort of community outreach networks that is in the community. So anytime you work with a community, an ethnic community, there are going to be different levels of CBOs and different types of CBOs. And so part of the outreach and engagement for DMH, the learning for us, is to learn the characteristics, if you will, and the specific flavor of these CBOs, and how to maximize the strength of each of the CBO in order to build more trust with the community and the individuals in order for them to sign that paperwork. Okay, 2 minutes, really quickly, I'm going to share with you some of our successes. We do have successes. We have lots of barriers and challenges, but we do have some good cases. So what we find is 50% of our individuals got connected to healthcare because they weren't connected before. So in our work, we have to really move at least 50% into signing up for healthcare. 50% also signing up for substance abuse counseling in tandem with the mental health piece. 30% of our population were homeless prior to the ISM, and so that part of the work is the housing piece. 30% of our population of our ISM are moving back to some productive activities, work, or some part-time work. One of our K enrolled member has lost more than 100 pounds. He uses dancing, Samoan dancing, as a way of reconnecting to his peer group, and also to sort of his sense of self, that sort of self-efficacy. So there are many different cultural components, but for us, we ask the individuals, we work with individuals to identify for themselves what component of their cultural practice that's going to be really tying or building into their wellness practice. And then we try to augment that, highlight that, and push that forward. So just to, I guess, wrap up, pride and embarrassment. This is one of the barrier and challenge as well a component from our partners. So I kind of wanted to tie in with that, which is we want to highlight the pride because there is a lot of cultural pride within our Samoan communities, and we want to highlight that. That's that sense of strength and empowerment and self-efficacy. And then embarrassment of illness, disease, or mental illness, or whatever it is, problem behavior, we anticipate that it isn't about putting it out there. It isn't just, in other words, it's like opening your shirt to let other people see your vulnerability. But we have to address the embarrassment in terms of within themselves. What does it mean for me to have this weakness and vulnerability? And how can I take that, my pride, my cultural pride, to balance that, to accept my issues and problems, because my families and my communities are beginning to accept that, and how do I integrate the pieces of myself. And so that's been sort of our success and our wonderful work with the Samoan ISM. Thank you very much. I'm going to move us back to the next presenter.
Hi, this is Mariko again. Thank you for all of you who are sticking with us. I know we're presenting a lot of information. All to take a breath and sit with us for the last part of the ISM presentations, which will be the Cambodian ISM. And I want to say to my staff who are out there, I know you're listening, there were so many great ideas. I hope you noted them because I'm not above stealing good ideas. I have actually learned quite a bit from the other ISMs, so thank you guys so much. We decided to call our ISM Inc., which stands for Integrated Network for Cambodians. And as you may guess, our targeted population are the Cambodians, primarily in the Long Beach area, although we are allowed to treat people who live outside of Long Beach. To put the Cambodians in context, we have to understand that they are primarily refugees, which is a little bit different from being immigrants. And if we look at the history, in 1975, the Khmer Rouge took control of Cambodia. And what they did was unbelievable. They moved all the citizens in the cities to the countryside to work in camp, where they literally worked to death. So the first group of evacuees, Cambodians, came to the United States in around 1975, and most of them were students and professionals, either who were outside of Cambodia at the time of the Khmer Rouge. And then in 1978, Vietnam invaded Cambodia, and that was the end of the Khmer Rouge. And it is estimated that during that time period, over 2 million men, women, and children died. That is an incredible number of the population that were annihilated. We saw thousands of refugees fleeing, going to Vietnam, fleeing the Vietnamese and going to Thailand and other countries, and from there they were oftentimes sent to the Philippines and other countries in camps. So over the next 10-year period, about 120,000 Cambodian refugees came to the United States, and almost all of them were survivors of the genocide. The 2010 census is showing that approximately 37,000 Cambodians live in LA County, and most of those live in Long Beach. But we really feel that the number is undercounted, and so we estimate there are probably much more than 37,000 in LA County. One of the things that has happened is Long Beach has become residence of the largest number of Cambodians living outside of Cambodia. And one of the things that the community has been able to do is to get a section of Long Beach designated as Cambodia Town, which I think speaks to their willingness to work together and their willingness to have pride in their community. A little bit about PACS, or Pacific Asian Counseling Services. We are the lead agency for the Inc., and we serve children, adults, and families. We have 3 offices in LA County, and our staff has language capacity in 12 API languages as well as Spanish. One of the things that we're very proud of is that we have integrated ourselves very well into the Cambodian community. And this photo is an example of, if you see me, I'm in the middle with a purple outfit, and we are having a blessing ceremony with the leaders of Cambodia Town because we were successful in having a highway sign put on the 710 to show where Cambodia Town is. And this is the kind of work that I feel needs to be done in order to really understand any ethnic community. Right now we have we have 8 full-time Cambodian clinical and administrative staff members. So Inc. is made up of PACs and 6 community partners, and here are the beautiful logos from the various agencies. The Children's Clinic is the FQHC. They have 9 sites. The Asian American Drug Abuse Program, ADAP, is our substance abuse provider. We also have community-based organizations, Cambodian Associations of America, CAA, Families in Good Health, Khmer Girls in Action, which is our Tay-oriented group, and the United Cambodian Community. And together we have worked to make Inc. as strong as possible. And it really came from a philosophy that PACS has, which is that we use a strength-based approach, because we feel that community partners are the experts. So each of our partners, each of our nonprofits are bringing a different set of connections and knowledge. I want to refer you to the 2007-08 UC Davis project on building partnerships. And one of the things that they found is that many ethnic communities feel ripped off, that experts, academics go into their communities, gather information, and rarely does that information actually create significant change in those communities. So when we thought about our model, we wanted to make sure that we included community-based organizations and that those organizations would be reimbursed for the services that they would provide, in this case outreach and engagement. And we really treat our partners, I hope, they feel this, that they are part of the Inc. team, so we all work together. So when we looked at our Cambodian community and tried to identify challenges and barriers, we found some of the things that we expected, and then we found some things that we hadn't. Of course, when you look at the Cambodian community, as with other ethnic communities, there's a lot of suspicion and fear about government agencies, and particularly with the Cambodians, their experience with the Khmer Rouge, and also what happened to them in refugee camps, inflicted a lot of historical trauma on this population by so-called government. So for them, oftentimes they felt that government interactions are going to result in imprisonment, torture, or death. So their level of suspicion is actually grounded in their experience. As with many other Asian Pacific Islander groups, they are reluctant to seek treatment, and we see the lack of medical insurance, but also it's timed with the high rate of unemployment and the assumption that they can't get services because it's too expensive. And quite frankly, many of them have more than one job, and they can't take time off to take care of even their health issues because they might lose their jobs. There are also cultural beliefs that discourage some of them from seeking Western medical attention, and so they may instead rely on herbal medications. And then many believe that going to a doctor is a last resort. There's not much thought given to preventative care. So when they do seek a doctor, it's because it's pretty close to unbearable, and they are often then in an advanced stage of disease, which makes their treatment and recovery more difficult, but it also sort of supports their belief that going to a doctor is a bad thing. As with the other groups, we found that most of our adults are monolingual or limited English proficiency, and many of the Cambodians who came after 1978 were farmers with about a 4th grade education, whereas nearly all the women had no education. We have to also understand that the illiteracy issue is a major one because they don't read or write in Khmer or English. And when you consider that the Khmer Rouge killed many people just because they could read you understand that it was a whole generation that disappeared from the Cambodian culture. Certainly, transportation is a barrier for many of our older Cambodians. And there's also the minimization of feelings that Cambodians exhibit, which is that what they suffered under the Khmer Rouge or in the camps is so enormous, so horrific, that what they're maybe suffering now can't begin to compare. So there's a cultural stoicism that leads them to accept their current conditions, even to the point where they are uncomfortable sharing that with their family members. Of course, we know that there's going to be a general lack of understanding about what is mental illness. But in addition, many Cambodians practice Buddhism, and there is a belief that mental illness, as we describe it, may actually be coming from a previous bad karma, so it must be endured. It's a slightly different way to accept mental illness within the community, and maybe why a lot of people will not seek help. Certainly, we found this was a very big barrier, that Cambodians do not recognize the symptoms of mental illness in children. And on top of that, they are afraid that if they report anything, that their children might be removed. And this certainly happened with the Vietnamese community and our Cambodian community. In addition, in order to recognize symptoms of mental illness, we found that many of the behaviors that mainstream Americans would immediately not tolerate are very much tolerated within the family structure. So these kind of disguise some of the elements of mental illness in children. As my colleagues have mentioned, there is a strong denial about substance abuse and a much higher level of acceptance for the symptoms of alcoholism. And we also found that pathological gambling is extremely high in our communities. So I just want to present some charts of the demographics. I don't want to dwell on them, but currently we have enrolled 103 clients in our program. Our age is primarily adults and older adults. And female, well, it was kind of balanced it last year, but then this year we have 85% women and only 15% men. And I haven't looked into that closely, but it may be that some of the enrolled females stayed longer into the second year. You can see the outreach and engagement. And I wanted to point out that outreach and engagement is going to have to be ongoing. And it's just not enough to go to a festival and pass out flyers, as my colleagues have mentioned, that the most effective outreach and engagement we found is the one-on-one interaction between our community navigators and the possible client. We have, of course, the language barriers. And when we looked at the diagnoses of our clients, we found that most of them do have a chronic health problem, and that when we got some data from the FQHC, that as expected, hypertension and high cholesterol and diabetes are the top 3 medical diagnoses. We did not include heart conditions and cancer because those are treated by specialists outside of PCC. But we also looked and found that there were some diagnoses that indicate what we might call somatic symptoms, such as insomnia, headaches, dizziness, and that the doctors were also seeing a large number of depression, anxiety, and post-traumatic stress. When we looked at our enrolled clients, as you can see, most of the diagnoses were major depressive disorders. And that kind of surprised me because I thought it would have a higher level of post-traumatic stress disorder. But actually the staff said that many of the enrolled clients don't meet the criteria for PTSD because they're not experiencing nightmares or flashbacks right now. Instead, they're actually going through the long-term impact of the trauma, which has created a sense of helplessness and low self-esteem, a lack of hope, and all of these are why they are diagnosed with depression and anxiety. So some of the strategies that we've learned over the last 20 months is that we had to first identify how to work within our contract. And once we got that, things became a little bit clearer. We learned that we really needed to understand how to improve the access for our Cambodians. And I think everybody knows that Asian Americans have the lowest utilization rate for mental health services of all the ethnic groups. So it's not surprising that disparity is so significant. So one of the strategies that we really worked on is staffing. And there is an enormous workforce shortage for bilingual staff. We certainly faced it. And we found that in addition to just hiring bilingual staff, it's really important to look for personality traits. And I think all of our partners have done that, as well as the other ISMs. We really look for people who have kindness and warmth and a caring attitude, and most of all, respect. Because if you respect the people you are treating, they will return it with trust. And that is very, very important. So the photo on the side are photos of our community navigators and the PAC staff, a very diverse group. No, actually, I think I'm the only, no, two of us are not Cambodians. And then we were very fortunate. I say hire the right person, but it was just by happenstance that we hired a case manager who is in a job, and that it was his knowledge of Buddhism and his stature in the community and his connections that really helped us to use the blessing ceremony, which I'm going to talk about later as part of our healing practice. So it is really important to have those connections. I think the Korean group talked about having a minister on staff, and that made a significant difference. The second strategy is we actually found that we had to educate the community navigators or the staff of the community organizations first, because it turned out they did not understand mental illness the way that we thought they would. And so we had to really have sessions where we talked about their misunderstandings about mental illness, what they thought mental illness was, and then include them in as many trainings as possible so that they would be on an equal level as much as possible with our staff. We also found that the cultural traditions and values, we had to learn them from our Cambodian staff. And I'm just showing you an example of the different ways of bowing. That shows you right away that what your status is in the hierarchy of a population, and it's really important for us as staff to respect that and to follow those practices. We found that the initial 8 weeks that the contract had for outreach and engagement was not sufficient, and we were able, with the other ISMs, to work with DMH to allow for a more continued engagement process, and I think the other groups have shown why that's necessary. Everybody talks about just translating the materials, but you know, what we found is translating the materials in a culturally sensitive way takes much longer than we anticipated, and that the materials are oftentimes translated by professionals, but they're translated literally or technically. But they're not in tune with the educational level of the recipient, and so the technical jargon frightens people away and feels threatening. So we really had to listen to the staff in terms of the photos and graphics that we would use. So here's an example of a brochure that we put together in terms of what is emotional well-being. And you will notice that the photo is of a happy family, because one of the things that staff reported to us is if you have lots of unhappy, sad faces, Cambodians turn off to that. So we made sure that we included a happy family. And then we used very simple languages, being easily upset, not having energy. So we put it both in English and in Khmer. We found that it's very important to build a bridge for our clinical staff to meet the prospective clients, and in this sense, our community navigators were invaluable. Oftentimes they were meeting the prospective client and were not identified as therapists, but as colleagues actually of the staff that we were with. And, oh gosh, and then the warm handoff. So, okay, I'm getting feedback as to how much time I have, sorry. And we also tried to adjust procedures. So we found from feedback from the clients that the clinical intake was perceived as intrusive, and we were able to modify that so we could do it over multiple sessions. And as the Chinese ISM pointed out, asking direct personal questions is very uncomfortable, very Western, very direct. And Cambodians will tend to deflect or minimize their symptoms, so we had to understand that and take it more gently. We continue to struggle with trying to get more child clients, and certainly we need to educate not only the parents but also our partner staff. So this is our first flyer that we are going to pass out and use to try and engage more children. What we found also, it's very important to be responsive to the client. So our outreach and engagement staff had to prove their trustworthiness. It's not just something, you know, that you can assume they'll give you. So one of the things we found is that you have to address their needs at the level that they tell you. So whether it's housing, safety, food, clothing, our partners and PACs had to help them get these things before they're going to enroll in our program. So referrals and linkages were very, very important. But what we also found is that our staff, in doing that, because they're so kind and giving, oftentimes went above and beyond, and they helped their clients with many, many things like transportation, moving, negotiating with landlords. And this resulted in compassion fatigue and vicarious trauma for the staff. So we actually had to deal with that within our teams and trainings. So not only do we take care of our clients, but we have to take care of our own staff. No surprise that clients are more open to receiving medical assistance than mental health services. And the medical services were an important component. The other thing that we used was spirituality, and we used the blessing ceremony to tie into the whole concept of integrated care. Because in Cambodia, when people are sick, they go to the temple for a blessing. They connect the mind to their health, and they strive for harmony. So this is one of the outreach flyers that we put together to announce our blessing ceremony, and we conduct them on a quarterly basis at different wats or temples, and we invite monks from different temples because we want to avoid any sense of favoritism. And the attendees are a mixture of clients, staff, family members, prospective clients, and community members. They just drop in. But it's been wonderful, and the clients have found that they can socialize before and after the ceremony, and that has really helped them identify each other in a non-threatening way and has actually helped them develop strong relationships with each other. So I won't spend a lot of time on that, but here are some more photos of our blessing ceremonies, and you can see the different monks and how well attended these are. And that trust is very important in terms of the gateway to treatment. In fact, what we found is once the client trusts the staff member, actually a great deal of sharing takes place, and it's almost difficult to contain all of that sharing within the context of Western time. I think those of us who dealt with that know what we're talking about. Also, we have to educate our clients about therapeutic boundaries. This is not something that's Cambodian. So we had to teach our staff that even though the clients may want to bring them food or gifts or even money, we have to develop strategies to refuse those gifts and not hurt their feelings, because oftentimes the clients start to think of them as a second family. Support groups was also important because of limited staff, and we found that by starting these groups, we were able to work with them more in a different way. But first we had to overcome the stigma, because in Cambodia, under the Khmer Rouge, groups were ways to indoctrinate people and oftentimes ended in the death of the people who went to those groups. So here's some examples in this slide of some of the handicraft and art projects. I'm not going to dwell on them because of time. And we have to individualize our assistance to the needs. So again, I'm sorry I don't have the time to go into it, but we developed a bike donation system because our clients reported that they needed different types of transportation. And we found that it's important for the clients to get help beyond their home or their house or their room. And so we have found ways to take them to community activities and help them understand American traditions and encourage them to meet with one another outside the support group or counseling session. And we also try to help them find employment. We also found that as they better communicated with their children, especially adult children, they have better relations with them. So I'm going to just end by saying that word of mouth is the most powerful communication tool in our community, and that we are so delighted that now they're starting to talk, our clients, with other people, and those people are now coming to get help. And that's where we feel real change occurs, one person at a time in the community. Thank you. So I believe we're going to open this up for questions, and so we're going to look to our CMH. Okay, so Christy is asking for questions. I'm sorry, I forgot the last slide with our information.
Okay. So thank you all. This is Christy Higgins with CIMH, and I wanted to thank Dr. Hoang and Ms. Kahn and Ms. Park and Ms. Wen for your presentations and all of the information that you've provided. I did just send a chat out to everyone inviting you to pose any questions that you might have. So we're open at this point to hearing from the audience about what it is, if you'd like to make a comment or pose a specific question about what's been presented. At this point, we have no questions that have come in, and so as we wait to see if the participants have questions, I wanted to just invite our presenters, if there's any kind of final comments or closing summary comments that you'd like to make in the meantime.
We can talk. Yeah, and we're also open to clarifying anything that the audience may have heard.
Sure. So one question that's come up that's more specific to logistics is just asking about if the PowerPoints are available. Yes, they are. We can get those emailed out to you shortly. Another question has come in, and it says, can you please talk about how you help with income stabilization?
Okay, I'm going to repeat the question. We decided to meet together as a group, but in doing so, we lose the ability to be on an open mic. So the question is, can you repeat that, Christy?
Sure. The question is, can you please talk about how you help with income stabilization?
So how do we help with income stabilization?
Well, benefit establishment.
So this is the part that we didn't know.
So when you question income stabilization, I'm assuming that you're referring to benefits establishment or job training, job rehabilitation. So in each of the ISM, we have different strategies, but us is across the board with Samoan as well as with some of our other integrated service work is we always identify strengths and capabilities, and within the care plan process, even from point of admission, we anticipate what's the goal that the client wants to get back to. There are individuals who are going to need to be on Social Security or disability, where we develop we support them to identify resources within the community and apply. But then also for job training, we do have access to the local rehabilitation job training, as well as developing some resources within the community too, for voluntary and also part-time. And the Chinese ISM also have some.
Yes, as I mentioned, that financial stability and wellness is important in our ISM program. We do have every staff from the very beginning of outreach and engagement to current treatment with health navigators really walk with the client to the Social Security Office or Department of Social Services to help them with application for GR or application for SSI. Case managers help our clients to set up access, transportation support appointments, etc. So all these are very, very important part of our program, which really help our client to feel well. And we really advocate a lot for people who qualify for Social Security benefit to apply for SSI, and this is something that all our staff are involved, not just the case manager. So this is really a learning lesson, and from us, you know, we do put financial screening as the first step. So just to give you a sense of that.
Okay. There's a second question. How do you work around HIPAA when talking to families and other community members? So first of all, we would never disclose the identity of a client. So we, of course, we adhere to HIPAA within the agency and with our partners. When we talk to family members, we would always have to have a signed release. And we would not normally identify a person as a client to community members, at least in the gatherings that we've had. I think everybody's kind of nodding their head on that one.
So maybe to clarify that when we talk about this. So just to clarify, I wonder if some of the participants, when you hear us talk about problems in the community, that's at the general aggregate list of problems within the community setting. But once somebody is an enrolled client and start talking about their concerns and issues, that's all limited within the HIPAA boundaries. So we would need to have a consent. So hopefully that would clarify. Otherwise, if you can clarify your question.
Okay, thank you for that question. There's a couple more that have come in. Go ahead and respond. This is Christy. Go ahead.
Okay, this is Grace from QACC. Just again, we do work within the ISM. There's going on where, you know, my staff at our agency, as the therapist, will be speaking to the physician, but we obtain release forms just like we would in any other kind of mental health traditional contract. So there's a lot of release forms that we get signed because there's a lot of partners involved.
Okay, thank you for that. So this is Christy. I'm realizing our time, so I'd like to, if possible, get these last two questions in and have the panelists respond. I also wanted to invite folks that if you do have posed a question, we will ask our presenters to respond to you via email if that's possible after the webinar is complete. But let's get these last two in very quickly. The next question is, I'm a manager for a children's mental health program that targets the API community in San Diego. We found it difficult to form a connection with the PCP and churches, and that we are often dismissed stating that they are not looking to collaborate with mental health providers or that they will get back to us, but is unresponsive to our follow-ups. What strategies were used to cement the relationship with existing community providers, since it appears to be a reoccurring theme for O&E, outreach and engagement?
Okay, so I'm just going to repeat the question back. Oh, there we go. There's a question in writing. So the question is about difficulty engaging the PCP and the church, and how did we as ISM cement those relationships with physician, primary care provider, as well as the churches. So I'm going to start with the response, and if anybody wants to chime in, please let me know. So the way that the ISM was designed, we had to have a official formalized partnership with a health clinic. So I guess took care of that in that because we formalized that relationship, that the health clinic had agreed to work with us, and also that once the clients were enrolled in the ISM, that they had to make our partner health clinic their primary care provider. So again, one that's been a great benefit of being in integration. We've learned from our past, without integration, it is challenging when you have a number of different health partners. They don't return your calls. There's difficulty getting paperwork back and forth. But having this, again, formalized relationship, designated, identified partner, kind of took care of that. In terms of the church, it really is a matter of finding allies and partners and champions for mental health. So there, even with the Korean ISM and in the Korean community, there continues to be some churches who don't want to work with us, and some churches who do want to work with us. So we do look for those folks who are open-minded and kind of willing to work with us. We took advantage of a lot of pre-existing networks where our various partner agencies already had relationships with certain churches or already knew certain leaders in the community, and that helped. And I think the key there was our staff, the staff amongst all the different collaborative partners have already developed a strong network in the community. I'm going to hand it over.
For us, sometimes, this is some on ISM, sometimes we do have individuals coming to us who have existing primary care provider, and it takes a little bit of work to discuss the need to switch over to our designated primary health care provider. And in our assessment tool, we have health as one component of the assessment tool. And also with the ISM, we also have these outcome measures that we have to do the evaluation project with. And health screening and health status is very much a part of that evaluation tool. And so sometimes it takes a little bit of time for the client to agree to switch provider. But sometimes it does help when we use the measuring tool or we use the assessment tool as a way to discuss how holistic the integrated service is, and therefore the need to have us be able to connect with the primary care provider. Sometimes we also use our psychiatrist as one provider talking to another physician. So our psychiatrist is not above, calling the other medical provider to say, hey, I need to coordinate with you because I'm doing this piece and the healthcare needs to be connected. Or we have case managers go with our client to the primary care provider in order to get the response that we need.
Okay, thank you. I recognize I said that we had another question or two that were posed by the participants, but I also recognize it's now noon, which marks the end of our time. And so I will ask the presenters to respond via email to those of you who may have posed questions that we're not able to get to live, and just apologize for that. It was a rich webinar with lots of information provided. So at this point, I wanted to thank all of you who are still on the line for your participation in this webinar, for your questions, and once again to thank our presenters for their incredibly informative presentations and responses to questions. However, we are at the end of our time together. Before we sign off, I did want to remind you about the upcoming webinars in this series. The final two that are focused on the API population occur on Wednesday, April 16th from 10 a.m. to noon. And that topic's on the intervention within the context of the API families and communities across the age span. The last one will be on April 30th from 10 to 12 on community-defined practice, lessons learned from caring for our families in the API population. So we invite you to also participate potentially in our Building the Evidence Summit. You'll see displayed on the screen there on May 30th in Anaheim at the Crowne Plaza, where we will have an opportunity to have all of the various populations that have been part of this webinar series come together and talk about how we build evidence to create and sustain community-defined practices within our communities. As a quick reminder, you can refer to the CIMH website and the CIMH YouTube channel within the next couple of weeks to review the PowerPoints as well as many of the recordings recording for today, but also the previous recordings and webinars in this series, so for the Latino, African American, and Native American communities. And we hope you'll join us for the summit, as I just mentioned. Finally, we encourage you to take a few moments to please share your feedback as you exit the session. And with that, we will conclude our broadcast. So thank you again for joining us. Bye-bye.